Thank you very much. So I will start and welcome everybody to this webinar on artificial intelligence in surgical research. Here we will learn what is artificial intelligence and how it can be differently used in modern surgery, how artificial intelligence can be used to improve cancer outcomes, and how it is affecting the patient-centric healthcare. I'm Dr. Mariela Vasileva, and I'm a breast surgeon from Bulgaria. And I'm here as a representative of the Education and Training Committee of European Society of Surgical Oncology. And here with me this evening was supposed to be Dr. Raza Sayed, but due to some circumstances that he couldn't actually attend. So with me will moderate Dr. Carmela Caballero. She's a breast surgeon and chair of our EYSAC committee. So I'm very happy to have two breast surgeons moderating this session. And we are both very delighted to introduce our speakers. These are Dr. Dobromir Dimitrov. He's a general surgeon from Bulgaria, and actually he's a rector of Medical University of Pleven in Bulgaria. And Dr. Giuseppe Catanuto, and he's consultant oncoplastic surgeon and works in Istituto Clinico Catanese Mr. Bianco. So first we'll start with Dr. Dimitrov, and he will talk about how artificial intelligence can be used in screening of cancer. Dobromir, the floor is yours.
Hi. Good evening, everyone. I hope that everything will be okay with my presentation. Please let me know if there are some problems.
Yeah, we can see it. Okay. Yep.
It's a great honor and privilege to be with you this evening. Yeah, this is my first, I'm a little bit exciting because this is my first participation as the lecturer of European Society of Surgical Oncology. Today, I'm going to speak with you about artificial intelligence for improving cancer screening. First, let me introduce myself. I'm the surgical oncologist. I'm rector of Medical University, as Mariela told you. And my research interest and research scientific field is laparoscopic, robotic surgery, focused ultrasound surgery, and of course, all the high new technologies as augmented reality and artificial intelligence. I don't have any conflict to declare for this presentation. What is artificial intelligence? What definition we can use to be much more clear and realized for us better is a very short, but I think is correct definition, the ability of a machine to imitate intelligent human behavior. How does it look like? Most of the time, we are the doctors, the medical doctors, we expecting that in front of us we will have some humanoid robot, but this is not true. Sometimes our expectation, our fears is that artificial intelligence can replace us to take our jobs. We have to compete with the artificial intelligence, but this is not true. The reality in that moment, artificial intelligence is very complicated statistical, mathematical solution and process inside are really very, very complicated. In this part of the plan, you can see how many steps are using for sampling, for convolutioning, extraction of the data. In the left, our target is to present the number 3, and we have to learn the computer, the system, that this is number 3. This is what exactly artificial intelligence looks like right now. We have 3 different types of artificial intelligence. Narrow artificial intelligence dedicated to assist with or take over specific task. General artificial intelligence takes knowledge from the one domain and transfer to other domain. And super artificial intelligence. This is machines that are an order to magnitude smarter than the humans. Of course, the second and third kind of artificial intelligence for the moment and for the now is not exist. Alan Turing, probably most of you know the name of Alan Turing because of the movie The Imitation Game. He asked, can machines think? And his answer is, instead of trying to create a program that simulates the brain activity of an adult, why don't we try to make one that mimics a child's? So from there, with proper training, we would get the brain of a mature person. And this is what we're doing right now with the artificial intelligence. This is the first conference about the artificial intelligence performing in 1956 years. In USA, these 10 very experienced mathematics engineers create this conference and for the first time describe the principles of artificial intelligence. In the next slides, I will try to present you how the artificial intelligence can be used nowadays in the current medical clinical practice and of course in the practice of oncology. Artificial intelligence for melanoma screening. This is our target to present the unknown skin lesion and using by artificial intelligence and very complicated deep neural network to perform as a result to take the diagnosis that this is melanoma malignant. In this research, the authors can use the deep neural network using over 120,000 images of 2,000 diseases, subsequently compared with 21 board certified dermatologists based on around 2,000 histology-proven clinical cases divided into two categories. The first category is keratinocyte carcinoma and seborrheic keratosis, and the second one is malignant melanoma and benign nevus. During this learning process, convolutional neural network achieves performance on par with all tested experts across both tasks, demonstrating an artificial intelligence capable of classifying skin cancer with a level of competence comparable to dermatologists. In the next video, I will show very simple application of mobile application.
Changing screens. Once complete, you have the option of deleting any images you do not wish to keep. To take an overview image, simply press Overview, remove your molescope, and take the image like before. Again, remember to tap to focus on the spot. If you have additional spots to follow up with, select Next Spot and repeat the process. When finished, tap Done. Whereas the app is great for imaging and on-the-go tasks, the Derm Engine web platform is specifically designed to help you gather deeper insights while analyzing your patient's images. Combined with AI for clinical decision support, Derm Engine optimizes sequential digital dermoscopy imaging. Working together, you'll get the most out of all of the different features while achieving maximized efficiency, quality, and accessibility. Let's take a look at the computer where your images and patients are ready to go. In your patient's profile, you have several tools to help you analyze lesions. The image registration tool automatically rotates your dermoscopic images to the same orientation so it's easier for you to view. The evolution tracker takes these images and creates a slideshow allowing you to easily identify potential changes over time. Visual Search is an educational tool that retrieves visually similar images from a large database of confirmed dermoscopic images. This is to support you in your clinical decisions, so it's important to remember that the provided pie charts are based on statistics of similar images, and it is not a malignancy probability of the query image. If you see a listed image that doesn't appear similar to your case, you have the option of...
As you see, in the near future, such a kind of application and collection of database will help a lot to our colleagues to perform the excellent and very good diagnosis, exact diagnosis for the skin tumors. And this is indication for artificial intelligence, which can be happen very soon. Artificial intelligence in surgery. With the next video, I will present a very good demonstration of combination between the artificial intelligence and augmented reality, how the software can help to the surgeon during the laparoscopic surgery, where it's safe to dissect and where it's not safe to dissect. These software are created by several universities in the world. Let's see.
And other surgical site infections. What's also interesting is that we can rely on some of the annotations that we draw from experts. So this is some collaborative work that we've done with the University of Toronto, the University of California, San Francisco, Imperial College London, where we were able to engage experts from hepatobiliary surgery, minimally invasive surgery, and general surgery to actually take different images of laparoscopic cholecystectomy and to try to identify where are the safe and unsafe zones of dissection. So the go zone or the no-go zone in surgery. And what we were ultimately able to do was to actually train a neural network to automatically identify where is it most likely to be safe to start a dissection when you're doing your lap chole here in the green, and where is it likely to be a danger zone? Where could you possibly injure something like the common bile duct or the duodenum, as you can see here in red? And you can use that as an overlay to help provide feedback and education to trainees or junior surgeons who may have a harder time understanding where to start their dissection. Now, this gallbladder is very straightforward, but what we have found in subsequently analyzing cases where the common bile duct has been accidentally transected is that this model also performs well in the more complex anatomic cases, where we see the surgeon, in hindsight, has been operating in the red zone or the no-go zone, and potentially could have avoided creating that common bile duct injury if they had had the assistance of this type of artificial intelligence technology that isn't prescriptive. It won't make them operate in a certain area, but it allows them to draw on the experience of other surgeons to make a more informed decision about how they want to proceed with their operation.
As you see, it's a very complicated software using by special augmented reality process in real time, which can help to the surgeon to take a right decision. Of course, this software is prepared with a lot of previous videos from a lot of real operation during the clinical practice of the surgeons. Artificial intelligence in lung cancer screening. Recently, deep learning algorithms have replaced the classical approaches for automatic lung segmentation. This is the lung segmentation here, as you see, in the green and the blue. Current state-of-art methods use statistical finite element analysis of three-dimensional lung segmentation, improved by deep convolutional image to image network training, which was successfully implemented. Which is the step of deep learning model of lung nodule detection? Of course, the first step is lung CT scan imaging of subject performed. The next step is the pre-processing of the images. The next step is segmentation of the images. The next step is extraction of these features. And of course, classification using convolutional neural network is the next step. And finally, the software should give us the answer, is this malignant nodule or benign? A deep learning algorithm showed excellent performance comparable to thoracic radiologists for malignancy risk estimate the pulmonary nodules detected at the screening CT. Here you can see the nodules and how the software realized. This algorithm has the potential to provide reliable and reproducible malignancy risk score for clinicians, which may help optimize management in lung cancer screening. Artificial intelligence in cervical cancer screening. This is one of our newest research interests in our university. In the last few months, we have been started to think about how can we create the new software for cervical cancer screening. Fortunately, last month we have received national funding for this software, and next days we are going to start to creation this software together with the Technical University, Sofia, Bulgaria. Right now, I will present you the similar software which is appears in the literature. This is the cervix. We are going to use colposcopy for images, and we use the acetic acid. And here you can see that the different proteins, these different lesions of the cervix change different using the acid. The application of deep learning technology in the classification of colposcopy is helpful in solving the diagnostic performance of traditional colposcopy. There is an initial experience with different artificial intelligence methods developed by different neural networks, models, algorithms for grading and classifying colposcopy impressions, reaching sensitivity, specificity, and accuracy from 75 up to 95%. Supervised deep learning algorithm for cytological investigation. Here you can see that these authors from China using over 180,000 digital cytological images. Cervical specimen was sampled to generate 2 liquid-based slides. 1 randomized slide was allocated to artificial intelligent assist reading, and the manual reading conducted by skilled cytologists from senior hospital and cytological doctors from primary hospitals. HPV testing and colposcopy directed biopsy was performed, and histological results was regarded as a reference. The AI-assisted reading detected 92.6% of SIN2 and 96.1% of SIN3, significantly higher than or similar to manual reading. Artificial intelligence assisted reading had equivalent sensitivity and higher specificity compared to the skilled cytologists, whereas higher sensitivity and specificity compared to the cytological doctors. Here you can see the software, how the artificial intelligence evaluate the cells changes. If you would like to create such kind of new software, we have to have a very good diagnostic method. In this example is the colposcopy. We have to create a lot of images. With these images, we have possibilities to perform very good annotation of different changes of the epithelium. And with this, we will collect huge database. With this database, we have possibilities to train the model and to create the new software for evaluation of cervix epithelium. Finally, for my presentation, I hope that in the last 20 minutes, I convince you that human brain and artificial intelligence are collaborators, not competitions. And we hope that in the near future, the artificial intelligence will improve our medical results in our clinical practice. Thanks so much for your attention.
Thank you so much. It was really interesting. And I suggest, because right now we don't have questions in the chat, so I suggest we continue with the second lection of this evening. And so this is for Dr. Catanuto, and he will speak for artificial intelligence for optimization outcomes in breast cancer surgery.
Can you hear me?
Yes.
Right. I'm going to share my slides. Okay, can you see my slides now?
Yes.
Right. So first of all, thank you very much for the invitation. I'm very happy to be part of the EYSAC and very happy to talk about artificial intelligence with young surgeons. And obviously, thank you very much for the introduction. I work as an oncoplastic surgeon in Catania, in Italy, and I work at Humanitas. This is my affiliation. I'm not a general surgeon. I've been trained as a general surgeon, but now I'm a breast surgeon, and I've been a breast surgeon for about 20 years. So sorry if you will be sorry. I'm very sorry for the general surgeons, because I'm going to talk mainly about experiences of artificial intelligence in breast surgery. Sorry, can you hear me?
Yes.
Yes,
Okay.
we can hear you clearly.
Yes. So before talking about artificial intelligence, we have to step back for a while and let's start our conversation from the limitations of evidence-based medicine, especially in the case of surgical oncology of the breast. A couple of years ago, we performed a systematic review in order to produce a recommendation about the use of breast-conserving surgery versus oncoplastic breast-conserving surgery. And this was done with a GRADE methodology, which is a very good methodology used by the most important guidelines around the world. And what we concluded is that oncoplastic breast surgery, that is considered one of the most important advances in the last 20 years in breast cancer surgery, significantly reduced the rates of positive margins, but with a low certainty of evidence, and it reduced the re-excision rate for breast cancer during breast conserving surgery, and again with a very low certainty of evidence. So in other words, the field of surgical oncology of the breast nowadays is relying on a very poor level of evidence. Some of the outcomes that we normally sell to our patient as the great advance of oncoplastic surgery, such as quality of life, were so poorly explored. In fact, we had only 4 studies that were investigating at the time quality of life, and they were observational in design. So most of the literature about oncoplastic surgery is just observational. There are no randomized trials, and there is no chance to get high levels of evidence in this field, because this is obvious. It is not possible to overcome a lot of limitations of the design of standard randomized trials and apply all these principles to breast cancer surgery. In order to produce the recommendation after the systematic review, we asked the panel, the opinion of the panel, and in the comparison between breast conservation and oncoplastic breast surgery. And the panel, even though the level of evidence was very low or low, still strongly recommended oncoplastic breast surgery. About 36% of the panel, and the panel was done by the most important specialists from all over the world, including not only surgical oncologists, but also medical oncologists, patient advocacy members, and other specialists, radiotherapists, radiation oncologists, and so on. And again, about 43% of the panelists still offered a conditional recommendation. And this is a clear contradiction, because you are working in a setting where you are using very strong methodology to assess the evidence you got. And you finally conclude that the evidence is low or very low, but we are still giving a strong recommendation for the intervention, in this case, oncoplastic breast surgery. So in conclusion, these are the limitations of current current evidence-based work. And why clinical trials are failing? Because mainly, and this is true also in general surgery, because the hands of the surgeon cannot be randomized. And also, trials are a very lengthy, expensive process. And sometimes they are rather rigid towards the incorporation of emerging evidence. By the time you start the trial, there is something new. Maybe another trial is offering some conclusions, and this is not possible. It is not possible to introduce the conclusion you get from other trials into your protocol, because you need a change in the protocol, you need to resubmit, and obviously you are going to lose all the data that you gathered by the time you get the new evidence. So by the time you conclude your trial, the outcomes may lose relevance, and obviously you miss a lot of money, you miss a lot of time, and the information you get from your experiment is not really applicable to a new setting. And obviously there are safety and ethics responsibilities that I will show you later. Now the question is, can a new system based on artificial intelligence that, as was shown by my colleague, is able to produce prediction in a very accurate way, overcome the limitations of evidence-based medicine? Let's skip this slide, because this slide is about the definition of artificial intelligence, and this was very clear in the previous presentation. Is a computer system that is able to perform tasks that normally are requiring human intelligence, so visual perception, speech recognition, decision-making, and so on. I just want to highlight that nowadays, with a very high power of calculation, we can work on two different sides. One is the really so-called artificial intelligence that is, in a way, performing an inductive process. You got an enormous amount of data, you use this kind of statistical methodologies, and analyzing all this data, the machine, with a very strong power of calculation, is able to create connection among data and produce a predictive model. On the other side, you have a very more interesting model that is called mechanistic model. It's not really artificial intelligence. The system is not able to learn, but this system is a deductive model. That means that first you have the theory, and then using the theory, you try to predict the function, in this case, in our case as a physician, the function of a biological system. This is very interesting because the combination between machine learning or so-called artificial intelligence able to do predictions and mechanistic models will help a lot in the future, will allow us to overcome some strong limitations of the standard model of evidence-based medicine. And let's go into some example of artificial intelligence applied to breast surgery. I think that this is one of the most important studies recently published in literature. I'm very sorry because I've been struggling with the slides before during preparing my presentation. So you can see an old paper by the team of the University of Heidelberg by Georg Heil and Andre Fogg. Is about the identification of patients with breast cancer who get pathological complete response after neoadjuvant systemic treatment using an intelligent vacuum-assisted biopsy. This paper was recently, this is a paper of 2021, was recently updated on the JCO, and I think this is one of the most promising strategies, at least in breast surgical oncology. What is an augmented biopsy? It's something, first of all, let's talk about the setting of neoadjuvant therapy in breast cancer. You give a drug, you observe the patient, and at the end of the preoperative schedule, you operate the patient, and you want to demonstrate that the drug was really effective and you had a pathological complete response. That means that if you have a real pathological complete response, you need to perform an operation even though there are no residual cancer cells there. So the question is, can we have a system that is able to predict a pathological complete response before doing a surgical operation, in order that we can skip the operation or give just radiotherapy to the breast, or maybe observation without any other treatment? Once again, if the drug is effective, you will get pathological complete response, no cancerous cells in the breast. Right, so the idea of the augmented biopsy is kind of a combination of the information from a vacuum-assisted biopsy that you can perform on the breast after the primary systemic treatment, and other information. What kind of information? Well, clinical information, information from imaging that in this study are not digital imaging, but just information from reports, and then treatment information as well. So we already discussed this. To generate an artificial intelligence system, you need a training population in which the system, the algorithm, is going to learn, and then you need a testing population in which the system is going to test the connections that it is able to perform on the training population. Okay, this is the testing population of this study, and then there was a testing training population and the testing population, and then they had an external validation population. And the results are really, really interesting. And you can see here that the false negative rate when they went to the artificial intelligence augmented biopsy was in the external validation population down to 0. That means that the system, once well trained, is able to understand if the patient is really having a pathological complete response. With what comes after this, that means generating trials that once again can perform the escalation of surgical oncology on the breast, surgical procedures on the breast, maybe observation or only radiotherapy. I like these slides because it's very interesting. It's demonstrating what are the factors that are more associated to the good functioning of the system of artificial intelligence. And you can see that the higher the value, the higher the association with a good prediction. The most important is the parameter that they are going to evaluate into the model. For instance, obviously at the highest, at the top level, we can find vacuum-assisted biopsy with cancer cells and accompanying in situ cancer cells, and the diameter of cancer after neoadjuvant systemic treatment, which are very obvious clinical observations that, when are put all together within the model, are able once again to predict reliably the results of primary systemic treatment. Now, let's go to another experience. This is our experience of learning from narrative text. Nowadays, randomized trials are performed on a very narrow number of patients. Even if it's a very large trial, let's say 1,000 patients, 2,000, 5,000 patients, it's still a very narrow sample that is not really representative of every single individual that we got in front of us in our consultation room. So in the end, what we do, basically we act creating opinions on the evidence that is available at the moment. But we are not really acting using exactly matching information and information exactly matching the characteristics of your patient. Okay, so in the end, what we do is we are reversing the evidence pyramid. Okay, we got randomized controlled trials, but the randomized controlled trials are not really representative of an entire population of the single patients I got in front of me. And at the end, we treat that patient using our opinion. So the idea of the Fondazione Greta, which I represent, is a small foundation dealing with training and education and research in oncoplastic breast surgery. We decided to start investigating the opinions of the expert. And we created this very robust panel, which is including some of the most important experts as representative of the most important surgical societies of breast cancer in the world, from all over the world, from the States, from the UK, from Europe, from Asia, from nearly everywhere in the world. And we asked them, can you bring us your list of features that you use to evaluate your patient? And please comment. This was done to understand what we really need to examine before the operation and what outcomes we really need to examine to test the results of our operation. And this was done using two methodologies. The first one being a statistical methodology in which we extracted a list of words that were connected between themselves in the narrative text that we received from our expert, and then an artificial intelligence-based procedure that was called word-to-vec that was able to find in a corpus of books provided by the same experts that were part of the panel to identify what was the extent of connection between the words that they have sent in their narrative text. I know that this may sound very weird, very complex to general surgeons or breast surgeons as well, but I'll show you why this could be helpful. This is the corpus of knowledge that they've sent that we use to train the artificial neural network word-to-vec. And this is the statistical assessment that we did. You see how interesting is this? You see how the words were connected, what was the direction of the connection, and how they were, how semantic clusters were within the text that we received. And you can see that breast volume, breast density, and breast ptosis, volume, ptosis, shape are some of the features that we normally assess before planning a surgical operation for breast cancer. And this is something very easy. This is just, even in this case, a statistical methodology that is able to make a representational connection between one word and the other one, and is called word clouds, a very simple algorithm, statistical algorithm that is just calculating the frequency of associations. But you can see here that this system is suggesting some potential features such as breast volume, patient preference, family history, I don't know, high penetration, genes, and so on. On the other side, we had the word-to-vec. The word-to-vec was the artificial intelligence system able to learn word association and semantic association between words. What is the theory behind the word-to-vec? The theory is that when words are close in a text, when the distance between two words is reduced, the lower the distance, the shorter the distance, the higher the semantic association. So this is one of the final tables that we calculated. And you can see this is a list of outcomes that was extracted, and the list was again proposed to the panel, evaluated by the panel. The panel expressed its vote and accepted or refused the potential variable that you have to include in the assessment of outcomes, such as overall survival, surgical complications, local regional recurrence rate, re-excision rate. What we did with this number is just generate information using the artificial neural network, the word-to-vec. We provided information to the experts on how really in the text of experts, these words, in the books produced by the experts, these words are really connected. That means that overall survival with a score of 0.7 is really highly semantically connected, are really two words that are highly semantically connected. And as you can see, the agreement between the experts was up to 100%. So in the end, the system was able not only to identify a variable to be studied when you perform an operation on the breast as an outcome, overall survival, surgical complication, but was also able to inform us about the solidity of this variable. Is it really belonging to the corpus of knowledge of the expert? And this was done using the book that they wrote in the past. Now, why natural language processing, this technique with word-to-vec or with other algorithms, with other methodologies can be very important? Because when you use every day in your clinical practice, you are producing a huge amount of narrative information that is in an unstructured narrative form, which obviously you cannot use like laboratory data like digital imaging, which is a very important source of digital information. Every day you write clinical notes, you write theater reports, you write letters to GP, you write or read nurse records, but all this information is in a way cannot be used to extract relevant structured information. What we want to do in the future is to create a connection between unstructured narrative information and structured databases in order to produce an homogeneous structured information. I just want to give you an example. You certainly calculate every day your ICD-9 codes, and these are structured information. If you match words in the text of your clinical notes with ICD-9 codes, you will be able to create a connection between notes and ICD-9 codes in a way that you will be able to understand what codes are related to specific clinical condition. Right. We tested the artificial neural network for some other experiments, and the Word2Vec was able, as I've already explained, able to create connections between words. So we explored the field of potential complications associated to a specific technique of breast reconstruction. We created a list of complications that were necrosis, infection, scarring, hematoma, hernia, contracture, and extrusion. And we associated to two different words or three words that were representing the surgical technique that we use every day. For instance, autologous reconstruction. And you can see that autologous reconstruction, these two words, were closer to the words necrosis, infection, scarring, hematoma, with a precise score. On the other side, if you use the word implant-based reconstruction, the word representing complication more connected to these three words were infection, extrusion, contracture, and hematoma. A breast surgeon is able to understand that the system was able to identify two different semantic contexts. The first one belonging to autologous reconstruction with specific kind of complications, the second one belonging to implant-based breast reconstruction with specific kind of complications. Why this can be useful? Because one day, once again, you can have a set of words that is representing your patient, and you can connect it to a specific technique and to a specific set of complications that they can develop. For instance, if your patient is a smoker, is diabetic, has large breast, obviously can be more close to develop complications, and these obviously can be analyzed, creating profiles of patients on a very large database. So what we do in the end is create a profile of your patient with a prediction of the outcome. Now let's go to another aspect, which is the aspect of modeling and simulation, that most of the times is known as mechanistic modeling. Every day we fly with airplanes in a very, very safe way, and airplanes are not tested, putting an airplane in the sky and see if it's able to fly or not. We test before, during the designing phase, using calculation modeling and nothing else. It would be very, very expensive. Now, for a paradox in medical research, every day we test drugs on living human beings, which is, in terms of ethics, is a great contradiction. We only use the methodology by trial and error. What are in silico trials? In silico trials are a combination of information coming from the mechanics, the biology of, and the human anatomy, the physiology of an individual, a human being, a combination of all this information with all the information that we can get from statistics that we have already discussed. If we make this kind of combination, we can be able, in a way, it's a very complex process, obviously, we can be able to predict to predict in a very reliable way the effects of a single drug in a scale that could be individual, what we call digital twins, gathering all the information that can come from very huge databases, all the information that we have from anatomy, from physiology, all together with specific characteristics using either mechanistic models, especially for the physics, for the mechanics and so on of our body, and the biology, of course, with artificial intelligence statistical models, we can create very precise modeling of every single individual. And Greta is part of, is going to be part, it will be part shortly, but we are still working together, of a European project funded by the European Commission about in silico world. The purpose is to generate a lot of research in this field, but also is to involve physicians and specialists which are not scientists into this field in order to create models, in order to shorten the process of validation of specific devices or specific drugs. It is a big challenge. We have been dealing with this for about 1 year, and we are going to study simulations of a response to neoadjuvant chemotherapy in the setting of triple-negative breast cancer. But this is a very important effort that possibly in the next future, let's say in the next 5 to 10 years, will allow us to skip the initial phases of validation of drugs, saving a lot of money and possibly avoiding a human experimental setting, at least in the initial phases. In silico trials are not the only experience that is available at the moment. I just want to show this very interesting multiscape mechanobiological finite element modeling for oncoplastic surgery that was developed quite a few years ago and used for simulation of the results of surgery for surgical oncology of the breast. In this study, the experts are just simulating the mechanics of the breast. Be aware that the breast is a very complex biological system that is made up of different systems: the skin, the muscles, the fat. I mean, the muscle is not part of the breast, obviously, but the skin, the gland, and the fat are part of the breast. And these three structures, these three tissues, have completely different mechanics. So this system was able to simulate the deformation induced by scarring in a patient using a biomechanical model, using the deformities, the deformation induced by the scarring process on the breast. So this is my conclusion. I think that a lot of future tasks can be sorted by artificial intelligence and simulation. By the time we will create very huge databases and we will work together with mechanistic models, we will be able to create, this is not a short-term task, this is quite a long-term task, we will be able to create, as I said, simulation of every single individual. And this will allow us to overcome some of the limitation of the trials of the standard classical ABM framework. The most important thing is to get real-world data. Once again, we are wasting nowadays an enormous amount of information which is in a not structured form, such as textual information. And we need to get all this information, especially electronic health records, within our systems, and we need to extract information from there. And the transformation of unstructured data from narrative information will be one of the most important steps, but not the only one, because nowadays we should be able also to gather information from social media, from all the interactions that every day we have. I mean, what we use, what we consume, what we use, the food we have every day, with the final intent to perform, once again, personalized predictions of outcomes, I got a patient who is a single human being in my clinical consultation room. I want to explore with her, with him, I want to explore the potential outcomes, gathering all together all the information I have on her, and specifically in a personalized way. Thank you very much for your attention.
Thank you very much. It was fascinating, really, really interesting talk. I would now invite everybody to come to a discussion of our webinar. And I have a question because it happened that you started with something that is very actually close to Carmela. This is the omitting of surgery, the possibility for omitting surgery. She recently had also presentation on ESO and a large survey on the possibility to omit, to recommend, how to say, the MDT committee to recommend omission of surgery in breast cancer patients. So, and now what I knew before is that actually we are still not there. But now when I listen to your talk, it looks more and more that soon we will be there. And I want to invite also Professor Dimitrov here, because this is when Carmela asked me to fill this survey, I said, you know, in Bulgaria, it will just will not happen. Nobody will actually, because the question is, have you ever think about it? Well, in Bulgaria, we know we haven't. I suppose in many countries in the world, people haven't thought for omitting surgery. And I want to ask Professor Dimitrov what he thinks about it. Do you think we are close in mentality, maybe, for this option, at least, maybe the mentality of a doctor's first and then the mentality of a patient? Can we actually omit surgery?
Thank you so much for your question, Mariela. Generally speaking, our medical society, Bulgarian medical society, has a lot of experience with innovation. Here, the examples are robotic surgery, laparoscopic surgery, high-intensity focus ultrasound surgery we implemented decades ago. And that's why right now we have to concentrate much more in the artificial intelligence. We have a very good connection in the relations with the technical engineers in Bulgaria and with the IT companies. That's why I believe that if we create a strong connection with them, we have possibilities to perform very good research and investigation in the artificial intelligence. And of course, if we have so many research projects around it, the mentality and the philosophy of the doctors in Bulgaria will change quick as possible, of course.
And maybe I would like to follow up on that question, because as Mariela said, yeah, there's this part about influencing the mentality of the clinicians when it comes to utilizing information from artificial intelligence or data we gather from artificial intelligence. But maybe it's another thing to convince patients about the reliability of these data. But what are your thoughts about this issue? Maybe Giuseppe?
Yes, obviously, what we are discussing is not the standard of care. It's not clinical message. This is absolutely clear. These are trials. These are investigational. Personally, my point of view is that I'm sure that there is a subset of patients that can skip surgery. I'm not sure that avoiding surgery will be a benefit in terms of outcomes. And this is very important. I'm not sure if performing radiotherapy, or maybe for instance, why performing radiotherapy if there is a pathological complete response? If there is no cancerous cell, the escalation of surgery, but also the escalation of radiotherapy. I mean, by the time we haven't established and validated the methodology with any kind of, let's say, not only artificial intelligence in the so-called machine learning way, but the entire system associated to power of calculation, let's say, we need to follow standard rules, and we need we need to perform standard trials.
Yeah.
I'm sorry, but for the moment, this is not clinical information. This is just, I'm sure that your guy is going to start several trials. He's already started on elimination surgery after pathological complete response. I mean, anticipation of pathological complete response. And the first outcome he had, it was that preoperative biopsies are not really reliable. Simple vacuum-assisted biopsy are not really reliable in detecting pathological complete response. So the next step was the artificial intelligence augmented. But if you look at, in theory, the philosophy, I mean, the philosophy is working. We need to associate this without, first of all, with the standard that is still trials, and then the outcomes and so on.
Yeah. Maybe I would also like to ask our speakers about because today we have a lot of young surgeons who are participating in our audience. So 2 questions. One is, you obviously discuss about very advanced knowledge techniques about how to process these different data. What skill and what kinds of topics should we be incorporating in our surgical curriculum to enable our surgeons, the young surgeons, to think about how to use these kinds of data and techniques in the future? And probably the next question is that when I listened to your talks, you spoke about a lot of different advancements in technology, data gathering. Of course, we come from different types of settings: low resource settings, high resource settings. Do we think that artificial intelligence, the way we are developing these things for artificial intelligence, can it be used to bridge the gap for cancer treatments between high resource and low resource settings? Or do you think it might augment or further widen the gap? What are your thoughts about these 2?
If I have to be honest, I chose medicine 25 years ago because I hate the mathematics. Right now with the technology, with the information century, it will be much more better for our students, for the young doctors, to have much more knowledge about the mathematics, physics, statistics, of course, because as I present in my presentation, the process for the database collection and for deep learning process is very complicated. If we would like to present even for the engineers, we have to know how to present better and smarter and clearly to the engineers, because the engineer will create the program and software for us. That's why this is what we need to change in our curriculum, with the medicine education and for the general surgery education in the future. Probably Giuseppe will answer for the second question, because I don't have any answer about it.
I think that artificial intelligence, once developed and standardized, can be a great benefit everywhere in the world, and is a way to manage in a standard way, so reducing costs, optimizing outcomes, and can be used everywhere in the world. I mean, if I'm able to create digital twins, randomized trials are done in Western countries and are not taking into account population from other countries, are mainly done in Western countries. Nowadays in the States, in Europe, sometimes in well-developed area of Asia. But I mean, if I'm in low to middle income countries, what can I do? Obviously, the human beings that you have in front of you, that you are going to assist to cure, is completely different from, I don't know, an old age obese European. It's completely different setting. The standard trials cannot work in this setting. Artificial intelligence digital twins and profiling in general can be a great add in reducing inequalities. And this is one of the reasons why I really encourage everybody to deal with this topic. A long time ago, I'm older than Professor Dimitrov, I'm 50 now. I was very sorry because during the last days in my upper school, I met one of the first computer scientists in my city. And it was 1990, 32 years ago, and he was talking about modeling of cell populations, and I was so attracted by this. And then time after time, I had the chance to work with bioengineers, to work with computer scientists. And I think if I have to recommend something, first of all, be very expert in standard methodology. They should be able to understand guidelines, to understand the basics of medical research. Then stay attached to bioengineers, to computer scientists, read a lot of mathematics, of modeling, all this stuff that nowadays is available in all the database, in all the, like the PubMed and so on. You can get an enormous amount of information that stimulates your brain. And so on. But start from the basic methodology courses. These are very, very important.
I'd like really to thank so much to Giuseppe, because reducing disparities is one of my topics that I really, how to say, it's very important for me. And to hear that actually this topic, the artificial intelligence, can reduce disparities. And I was thinking all the time, yeah, yes, you're right. I think in a way, the problem comes with real world data, I would say, because it's real world. So the world is real in one part and also real in the other. But yes, I agree with you. It can be a great tool to reduce disparities, and we should work, I think, more in this direction. There is one last question from the audience. I wanted to ask. And it is, do you know if artificial intelligence can be used for predicting cancer occurrence? I read it like this. Do you have any information about this?
From my knowledge and from my experience, still not appear such a kind of software or application for using, but probably in the future, with the collection of the data in the oncology, different biological results, CT results, MRI, probably can be happen.
Well, in my field, secondary prevention nowadays is even more in the hands of artificial intelligence. And there are, there is evidence coming out that artificial intelligence is able to outperform the ability of radiologists in reading screening mammographs. But obviously, even in this case, it depends on the kind of digital mammography you're going to do. But anyway, nowadays, it is just secondary prevention, but it's very close to become standard of care.
And one last question then, because you said that artificial intelligence can be better than radiologists, but what is the current stage? Is these tools now used to advise doctors or to replace them?
Not at the moment, it's still used to advise, but it's going to be close to replace doctors. And you can imagine the saving. You can imagine the saving, the huge amount of money you're going to save. I'm very sorry because I'm not very skilled in this topic. I haven't been dealing with artificial intelligence applied to imaging. It's not my field of research. But we are very close, and you know that the screening process in breast cancer is very, very expensive, and this can cut costs.
Yeah. But maybe, Mariela, as a follow-up question to that, do you think, can evidence from artificial intelligence alter or replace the surgical experience of a surgeon, let's say a breast cancer surgeon? I'm imagining a trial where the surgeon will be provided with two things: either One is an advice from an AI, let's say a robot saying, this is the possible outcome if you do it like this. And then on the other hand, he will need to probably think of, okay, what could be the outcome if I just do based on my clinical experience? And then we can assess the outcome at the end. But do you think surgeons might be replaced, or the knowledge of surgeons might be sort of replaced?
Are you asking to me?
The surgeon can be support from AI.
That's
This is
good to
the
know.
correct idea. I cannot imagine that the surgeon will be replaced from the artificial intelligence, but together, cooperation between our brain and the artificial intelligence can be improve our surgical and cancer results, of course.
Yes, I do agree. And my point of view, I may surprise some breast surgeons, is that robotics in surgery is going to be a great step ahead in, I mean, this collaboration between human brain and artificial intelligence.
Yeah.
And so don't be scared about robotics. It's just a tool. And we need to customize it to breast surgery, but it will be a great step ahead in standardizing surgical procedures.
Okay.
It's great news that we have a job. Everybody who are here, so good. Thank you so much, everybody, for this excellent your presentations and the discussion. It was really interesting, and I hope we can have you soon again on our webinars. And really, I enjoyed a lot this evening, and I want to wish everybody a good evening and good night, and hope to see you soon.
Thank you very much.
So much. Goodbye.
Thank you, everyone.
Thank you.
Bye-bye. Bye-bye.
Bye.